Fantastic. Fantastic. I'm just going to switch this light off a little bit so I can see things better. I presume when you first saw this image and you wondered, well, I've seen enough, those sort of cases before. And well, I see them more often. Some cases are mine. I'll discuss my cases. I'll discuss other people's cases. There's no judgment in this webinar. It's just trying to understand, as the clinicians, what can we do to plan better to prevent things from happening, and also understand where is our responsibility, as well as where it lies, and as well as where does the patient's responsibility lie. In many ways, as you can see, my seminars is a thought-provoking seminar, rather than telling you what to do, because the name of the game in the ICU of DP College is to teach you to diagnose and treatment plan and think better, rather than looking at point blank range and making decisions as you go. So this particular patient, I think, is about 48, 50, and been in practice on and off for a long time. She turns up and then something happens, we fix it up and disappears. Turns out something happens, fix it up and disappears. And this is a pattern. And a lot of you have those patients that come and go. And at the end, when they come back to you, you find there's so many other things done, have no idea what's going on, that not much thought pattern has occurred in looking at raw mouth. And that's what prosthodontics is planning the cases and controlling the cases and doing all things. So in a way, when we talk about our patient, particularly in this case, we have lost freedom of bridgework, and we lost freedom of bridgework. The patient comes with a bridgework in the hand. It's more than that, actually. Been seeing another dentist, haven't seen it for like 4.5 years. And I got a call from a dentist saying, can we have your dental records? I said, why? He said, well, we need to know what implants you put in because the screw is fractured. Well, I can tell you straight out, it's 600X, regular platform, Southern implants, which is a very similar to Edmond and Brennermark, 3 and 4, 600X, regular platform. And there was a problem, couldn't understand the dentist, but we tried to help him as much as we can. Eventually, patient rang me up and said, well, can you help me? I said, I'm happy to help you. So you're most welcome to come back and let's look what we can do for you. So she comes up with a bridgework and says, doctor, you did a good job. And you must have had this before because it's very common. Okay, in the specialist practice, you get the same. People tell you did a good job. Not many people admit it, but I can admit it that we did this bridgework for the patient. I haven't seen a patient for a while, but we were asked that did a good job. So from my point of view, I don't look at this as I'm offended. I just look at this, okay, now you're a professional. Remove your ego, remove your other factors, and see what the real problem is, and see if you can really help these patients. And that's what I think. So you can see on the left there's a fracture screw. That fracture screw belongs to not to the external hex, but belongs to this other implant. I'm not going to measure what the implant is. I don't want to deal with that, but that's outside. We don't talk about implant types. All implants are today's modern implants. If you look at the basic top, let's say 8 implants, they're all good. So we're not going to talk about the design, the macro design, the micro design, the surface texture, etc. We're not going to talk about that. But if you want to talk about it, you can ask me questions. And we'll ask some, I'll prefer if you sort of come with some questions along the line. And Natasha, would you please stop me and tell me there's a question so I can answer straight away. So this is the problem, but it's not about what do you do when you get a screw fracture. The problem is in our college, we talk about how to think and what to look for. And I'm hoping that my technician, Alex Tayan, will be here. We can discuss some complex case. You can see how we think about this. But the important part is we teach. And if you have any questions to ask about the college, let me know now at the end of the lecture. Happy to talk about it. But it's important to understand that every 12 modules is well planned and well integrated to teach you in getting you next step in your dental career. Having said that, let's go next step. So when we talk about success in implant dentistry, many times when you look at success that's in the literature, they basically want to see if the implant's stable, there's no pain. There's it's surviving. In other words, it's been over 30, 40 years. Survival rate is almost like a success rate because, nobody lost bone, but prosthesis is successful, it's working, there's no infection, there's no numbness, etc. And the tissues look healthy, so it's a success rate. And that's very well said. But no one's ever sat down to look at prosthetics from another angle. And I think in 2012, Papa Spiridakos and his colleagues, they look at to evaluate from a patient-centered point of view. And Gallucci did the first evaluation where he talked about, I know it's a bit boring, but I'll just go through these slides before I go to the next one, and you'll be all happy. I'm going to show you. You got to look at the implant level. And bone loss is less than 1.5 first year, and then annually 0.2 millimeters. There's no mobility, there's no infection or pain, obviously. The soft tissues, you want to have a probing, is less than 3 millimeters, there's no separation, reduced bleeding, swelling, plaque index, thicker keratinized tissue. We all understand those things. And then we look at the prosthetic level, is a complication is minor, we can fix it with chase as a major, where we have to redo the prosthesis and other laboratory works required. Aesthetics, the problem, function problem. And finally, we look at the patient satisfaction, patient level. In other words, is there discomfort, and can they chew better, can they talk better, are they happy with their life? So all these things are very important. It appears that there's a inaccuracy to assess if you're going to assess each one individually, you're not looking at the whole picture. So in this case, when a patient comes up with a problem, this is initially, and we need to look at the patient as a whole. So part of the reason why I bring this case up is I want to go back in time, okay? And back in time, we saw the patient in 2013, had this existing bridgework in place. As you can see, there's optimal bone levels. Everything has been done correctly. There are 10 millimeter implants, 3.25 millimeters. This is about 3.7 or 3.6 millimeters. This is 3 millimeter in diameter, 4 and 3 millimeter diameters. But it functioned for a long time. So what happened from here? I haven't placed this work, it's done by another practitioner, but this doesn't matter. I want to get to the point in a different way. So what happened from here? When you think about it, we didn't see the patient until about 2015, and patient returns, some crown has been placed. Obviously, the root, the pulp has been cooked. I can see that. There's a area here. And I'm not worried about how the crowns are placed, but basically been placed. It's patient, and you can see there's a fracture, and there's implants fractured, and so the prosthesis had come off. There's also a fracture of the screw here. You can see the screw fracture here. I haven't got that arrow, but I should put the arrow in. So that we have a problem of screw fracture here. At the same time, we have a problem of an implant fracture here. It's well integrated. It's well also integrated. And the problem we have is, okay, well, we really can't save this implant, but how do you take this screw out? Because the gum is about here, and from here to there is about almost like a 10 millimeters. So to take this screw out is it's a nightmare. And if you had the opportunity to have these problems, think about it before you touch them, because there's too many things that go wrong. You actually rule out implant. So it's very, very important that you understand how to retrieve those screws. There's a lot of retrieval kits, but not all work as well as, well, you should talk about your rep and get them to come and help you. A lot of the reps will have an idea what to do, but you need to know what you're doing. But nevertheless, taking this screw out was more of a nightmare than removing this fractured implant. Okay. And when people tell you, oh, it's not an issue, you can just trephine the implant out, that's the biggest rubbish that you'll ever hear, because you trephine the implant out and measure bone. You have a huge through and through defect in the bone, and that's quite dangerous. So from that point of view, we have a problem. And the other problem is that when the bridge was designed, we knew that this type of implants, you can't just go direct to fixture, such as here, because that actually will expand the attachment, the wall that you're actually housing the abutments in, and you're going to increase your chance of implant fracture or a screw fracture. But what caused the implant fracture, what caused this problem, that's another story we need to talk about. So the problem is we need to think outside the square, as we always do. You know, it's a minor or major complication. You all know it's a major complication, and patients are very distressed because they spend a lot of time, a lot of money, and especially those patients who go into different dentists for different treatments. So there's not a good regular examination and report and understanding what's where, knowing your risk factors and controlling your risk factors. So I see a lot of these patients. So we went ahead and we reconstitute the quadrant 2, if I could say. The root therapy was done, and then we removed the implant, did the root therapies, and placed the external hex, because I like the external hexes. I can assure you, a lot of you may feel that you know, this is not, I prefer some internal connection, but I'm most happy with direct external connection because the actual prosthetic screw is very, very strong. It actually takes a lot of load. And we know that if something goes wrong, we can always retrieve the screw and retrieve the bridgework and have a look at the situation. And we place a special abutment to reduce the stress on the distal implants, so screws don't break, so that if anything happens, we know how to get to this area. Nevertheless, we did manage to, you know, fix the problem. And this was in 2015. So what happens after this is that we don't see the patient for another 4.5 years. And patient turns up, he says, "Doctor, you did a good job, because my dentist said that you put old-fashioned implants on that one, and he thinks you should put new-fashioned implants. If you look at my mouth, he's put all the new-fashioned implants in my other parts of my teeth, and this is where the problem is." I say, okay. So the problem is, I would know what the problem is. How do I go and explain this to the patient? And how do I explain to the patient that, look, I just want to have a look. So, you know, like, whose fault is it? Is it my fault or somebody else's fault? Is it the patient's fault? And one has to be very careful how we talk to our patients, because it could be anyone's fault, or probably a combination of things that have gone wrong here. And now, these are all the composites bonded to the existing bridgework because she want to improve the smile. Sometimes I do a lot of temporary work. So don't worry about these composites here, because at the time when I did it, I had the occlusional control, but I haven't seen the patient for 4.5 years, and she's been to a few practices, and I'll show you some images in a minute. So when it comes to, I was trying to relocate the implant and trying to put the actual implant back in the mouth, and had a lot of problem in trying to relocate this. And I'm saying, this is not quite right, because of the dentist that's currently treating the patient said to me, I need the implant because the screw's fractured. I need to put a new screw so I can restore this quadrant. But the bridgework, my concern was the fact that, well, I can't put this in, so something's not quite right. When we look very, very carefully, something doesn't look right. Okay, so in this particular case, we have other problems as well. So bridge is on the floor, as you can see, and we have a problem. If anyone wants to ask me a question, you can ask me a question anytime, by the way. So I look back, and it sounds very strange. This is a healing abutment which I placed on number 2-4 implant. And I can see that this abutment is somehow traveling across. It's just as moved. Now, we all know the implants don't move. They stay in one place. And it's loose. So immediately my mind changed, is that the dentist did not diagnose that the tooth number 2-6 implant has failed. And it's failed for an unknown reason. And it's because it's failed, or it's not my responsibility, it's the other dentist's responsibility to go back. And anyway, I had a good chat with him and explained to him there's other factors that we need to consider. And if you look very, very carefully, there's some new restorations on the opposing arch. That wasn't there before. And they're quite wide. Obviously, the patient has a lot of say in this type of restorations. That's what they want to see. And this is what they want. So he gave what she wanted. There's no question about that. In his mind, he did the right treatment. And the patient was very happy until the bridge fracture. So what do we do from here? I mean, where do we go from here? This is when I removed the distal implant. We cured the socket. And this is periimplantitis, but it's not because of periimplantitis. Okay, and I'll come to it in a minute. So I'm going to provocative statement to make in this particular case. The statement is that, is it possible that the clinician may be part of the etiological factor in implant? Should be A, missing, I do apologize, loss. Or is it possible that the patient may be part of the etiological factor in implant loss? So that's something that to consider. And while you have a patient who's very apprehensive and wants an answer, has been already brainwashed who's wrong, you need to maintain your cool and take your time, make an assessment. But just look at the patient for a second, risk assessment. You can see we have a dry mouth. There's loss of papilla here. There's a chronic inflammation here. There's a caries here. Poor hygiene. The periodontal factors here. There's definitely muscle pocketing here. And we didn't get a chance to measure the pockets, but I managed to get some photos while we're there. So always take a photo. That is your best diagnosis. And we have a high caries risk patient, and yet the dentist feels very comfortable to go ahead and place implant support crown, tooth support crown, another implant support crown, and that made better sense to the dentist. And between 2000 what happened? You can see that we are opposing all these new type of restorations. These are all implants. It looks very good. There's nothing wrong with it. There's the old restorations that has been nothing done to them. I'm not sure why, but they were happy to restore whatever he could restore. But what I don't understand, when you regularly see a patient, how do you manage to ignore the fact that you have poor hygiene, chronic gum inflammation, periodontal disease, and caries, high caries risk? So how do you go and place those restorations without giving considerations to overall mouth health? And the problem I see is in the teaching of dentistry, because maybe people being taught, unfortunately, are not taught to do risk assessment, or perhaps the dentist treating patients don't really care about everything else. They just want to do the quick buck, fix situations, and then whatever happens, happens. Well, I can tell you one thing. As a prosthodontist, we pick up all these patients, and I need to give some sort of scenario, which way we're going to go. If you have these checkups done every 6 months, and we're missing all these other areas, and we're happy to place all those implants, there's something wrong with our decision-making process. And this is why those who think like this, you should do the college program, because we teach you how to think. It's very important. Now, the problem I see here is not just what's been done, but the problem I see here is the fact that we have to fix this patient up. We have to put this patient into the, back to function. Improve the aesthetics. But what I have to do is, because I can't relocate the implant bridge back on, we decide the section, remove the part of the crown that's supported by the implant on distally, leave a cantilever, put this back in the mouth, and you can see that even with the implant in place, the opposing implant crown is directly the only guiding tooth to the bridge. Everything else is taking a load on that bridge. So what I don't understand is that when people are taught how to place implants, are they ever taught anything about occlusion prescription? Is there guidelines? Well, there are guidelines. The biggest problems we have is every patient is case by case. So the problem is when dentists are being taught by the occlusion, and it's quite simple, and yet it's very complicated. But most simple things are really simple. Because it's complicated, it's the fact that it's not being well taught. Now, I would have loved to get on the phone and explain to the dentist that this is what I think, which I tried. But he totally couldn't understand what I'm talking about. And that is more concerning to me than anything else. Because it's quite obvious that there's this guiding area and it's to be adjusted. And that's loading onto a tooth on 3-5. So the way I see this case is we could have prevented this problem from occurring. And it wasn't the fault of the old-fashioned implant in the first place. You see, we are born in this new era where clever words are being used to make people think otherwise, just like there's some clever words being used in our COVID situation, the new me or the new era, the new normal, whatever it is, doesn't matter. But when it comes to really biology, it doesn't matter which era you belong to. I can assure you one thing: the same stone or same coconut that fell from the tree and hit the caveman in the head did the same painful damage to his head as it would be falling on a modern human head. Will do the same pain, same damage. But the problem I'm trying to explain is that when you put an artificial device in the human body, such as not dental implants, should be oral implants, because dental implants are the wrong term, should be oral implants. Dental implant is like a cast post, or a para post, or a fiber post, or a pin. That's a dental implant. Oral implant is to carry out a missing tooth, to support a missing tooth. So to me, although the work is excellent, when you have a loading, something must give. And this is the problem, is that when you keep loading, there's an overload. Now, up to this point, when I got the patient comfortable, and then we adjust the occlusion, and I explained her the problem, then she understood me that it really wasn't my fault. It could have been, but it wasn't. So in many ways, when you are facing this problem, you need to rethink, not just talk to the patient and argue the point, just show and tell. Show and tell. And when you do the college program, we'll teach you how to think, and you have all the armamentarium to be able to treat these patients, make them understand the problem, own the problem, most importantly, and then they will come back to you and realize that, I can't be a traveling Wilbury going from one place to another. They'll be stuck in maybe your surgery in your time. So you have a long-term maintenance program for this patient. You see, in many ways, depends how you look at things in regards to occlusion. There's no formulas. It's case-by-case basis. This is the thing that people don't understand. Everybody wants a recipe. There's no such thing as recipe. Every patient is a new recipe. So we adjusted and the patient was happy, obviously. Okay. Anyway, just a little note on biomechanics. When we talk about biomechanics, well, in physics, pressure is force over the area. Okay, if you have a small force or a large area, it's low pressure, but you have the same force on a small area, the pressure increases. And with this pressure comes a deformation, which is called strain. Okay, so in the mouth, when you have a strain deformation of the rest of the material, you have strain deformation of a tooth, and the tooth is made of dentin and enamel and cementum, and different thickness and depth of each part of the tooth has got different strain measurements and different hardness measurements. And most important, then you have the bone. So when you understand that between the tooth and the bone, there's a periodontal membrane that can absorb the load. If you look at some of the Lindy studies back in the 60s, and when you remove the force, it recovers. But with implants, there's no periodontal membrane. It's only the implant will move to the stiffness or modulus of elasticity of the bone. Okay, so what happens is that when you increase strain, osteocells will pick up. It's called Rankel system. It's another messenger system. I don't want to go into this, and then it activates, and you get cytokines release. You get osteoblasts are formed. And then you got osteoclast, and there's a bone remodeling, etc. And so far within physiologic limit, okay, it all looks good. But once you start pathologic overload, then you start looking into microfractures. So how does it relate to our case? So I really talk to the patient at the same level. I've been up here in my consulting room. I still want to talk to you. This is the problem, because no one ever talks to the patient. You probably heard of Frost in 1972. One of the magnificent, is a genius, Frost, on a bone biochemistry and biophysiology. So when you look at this, okay, now replace the implant. Okay, now in here, that's more like a D4 bone. This is more like a D2, and it can be even D1 bone. In this particular case, we have titanium. Now, titanium has a high modulus of elasticity. Now, when you load the titanium in a bone that's very strong, okay, there's more chances in an implant with a weaker wall that's splitting and fracturing, or having a crack along the implant line, than actually losing a screw, which happens in the next stage anyway. Or could have lost, have a loose screw loosening, and because of the raw cooling, the jiggling effect, there's a fracture of the implant surface. And the other important part is the fact that in this case, okay, you're looking at a bone and implant interface, okay? It's related to how much stress you put on the system. So we should be very careful when we promise our patients that, oh, now the implants are better than a tooth, you're good for life. No way, you can't do that. When we come to this side, into the D4 bone, it's got the most lowest modulus of elasticity. And yet the titanium has high stiffness. So naturally, there's more chances, if this is loaded, the bone's going to give in and not the titanium, because it's softer bone. So when we explain to the patient, they understand why things happen this way. So we know that we place the implant, then we establish integration between a good 3 months, and I mean to maintain integration. Natasha, is there any question up to this point?
There are no
None,
questions.
none at the moment.
All right.
Good.
No, I'm
So,
just checking none.
thank you. Here's a patient that presents. It's a very interesting case. We issued the mandibular bridge, okay, on acrylic. And we also issued the upper left segment. She needs to come back and more work done here. And because this was done in China, where they have calcitate implants, and God knows how this is going to work. That's joined to the tooth. Don't ask me about this, because I don't join implants with teeth, never have, never will. And this is a minimal oral opening, so we had a lot of difficulty, hence the reason we have short distal implant, we just couldn't get there. But the implant was issued, as you can see on the left side. Patient was happy. We had acrylic teeth with the zirconia on top, and then posterior maxilla. And I thought, well, you know, there shouldn't be any major problems. The problem is that patient comes in, we finish the treatment, and just disappears for 2.5 years. So we came recently, a few days ago, as I was in the process of preparing this lecture for you. And so, doctor, my implant bridge is loose. My initial concept was I'll probably got screws in, and you know, we just come back in and retighten or change the screws and restore it. Well, interesting fact is, when you take an impression, when you take an X-ray, and that's before, this is current. Well, what was the patient's role here? Patient's role is to maintain their, you know, the maintenance program, and to be part of the maintenance program. That's the whole thing. That's the whole important part. But patients failed to come for 2.5 years. And I have no idea what's happening. Since I've been to local dental clinic, I can see here a calculus formation during neglect. When you have lose an implant, when you lose a screw, I think that's dislodged. I'll show you in a minute. This is actually jiggling on two 5 implant on the, you know, on the external hex implant. That was the only screw that's maintaining. You have a fracture of the zirconia buttons here. And you can't see it here, but they've also have a fracture here. I'll show you in a minute. So we're looking at the next slides. When I removed it, this is the only screw that was holding it. You can see that there's a button of the zirconia tubes. We have a passive buttons. If you don't understand what that is, don't worry about that, but we're just talking about the bridge case. And we have 2 of these buttons. This one and that one fractured. The only one that's holding it is the regular platform. So the question is that when we have a screw loosening, if it's not immediately taken care of, you lose bone. You lose bone right here. Okay, and you lose bone because it's quite obvious that, you know, looking over here and looking over there and over here, we definitely lose bone. Well, it's not that tragic. We can still reconstitute this patient. But it makes me think in terms of why this would have occurred. You know, patient hasn't been for 2.5 years, been to local dentist who's been cleaning teeth. But for some reason, when we have our patient recall visits, do we just clean teeth or we check their occlusion and make sure that everything's normal? Or, I mean, what do we do? I mean, recall visit is not just a regular hygiene case. Look at the overall function, overall stomatognathing system of the patient. In this particular case, for 2.5 years since we issued the bridge, I'm not sure what's happened in the patient's life. I'm not sure what she's done, but nevertheless, as a clinician, as a specialist, I would like to say to myself, well, what could I do to improve on this so it doesn't happen? You know, could I have improved, you know, prosthetic design? And maybe implant would have been placed in an ideal spot. I don't think so. Could I improve in prosthetic design? Maybe. Maybe there's a component fault. Maybe there's a technical issues that should be addressed. So, you know, me and my colleague, Alex, are you there? If Alice is not here, that's fine, but if he's here, we're going to have a nice discussion about what we think this case is, which way it's going to go. But nevertheless, the problem needs to be looked at, not just a blame game, but perhaps what could I have done to improve the situation? So one of the problems is the blame game. The blame game is so easy because it's not my fault. I can assure you one thing. Whenever you say it's not my fault, as a professional, we don't look that good in front of the patient. We should be empathetic and listen to our patients, although sometimes it's irritating, I can tell you. But you sit back and just listen to the whole story. And I normally say to the patient, let me just think about this. I just really want to get to the bottom of this. So I have to learn from this. And to me, this is very interesting. And people understand that. Most people understand it. But also, most people know what they've done with this bridgework, right? They know what they've done with it. So they're not telling you how to stop. So the fear of the unknown, a lot of work making people believe in falsehoods is frequent repetition of familiarity is not easily distinguished from truth. So this is the problem you see we have. If you say it's not my fault, it's not my fault, or it's the patient's fault, you actually will never ever get to the truth of the problem. So when I look at a patient and when I remove the bridgework, and you can see the soft tissues are in an optimal position. Okay, I mean, you can say, well, this is an angled implant site. This is probably more pathway place, and maybe I can say, well, maybe the actual tubing, the zirconia tubing, is very weak. Maybe the angle of the implant was just in the actual zirconia tubing. That's why it broke. Okay, maybe I didn't do the correct inclusion platform. Maybe she was loading. I have no idea what she was doing. Maybe it's a change in inclusion. Maybe someone did something else on the appointment. I have no idea what's happening. The lower this complex work is on fine tuning. If you don't do fine tuning, something is going to give. And this is very common, not just in the first 2.5 years, but usually happens after 5 years and happens after 10 years. Okay, maybe material went over fatigue here. I have no idea, but my job is to reduce the chances of this happening. It's very important that we think of, am I going to go back in and tell my lab, we'll just, you got the CAD file, that means the digital file, just mill another one and we'll stick it in. No, that's not the answer, because if I have the opportunity to redesign what we have, then I will create a better outcome. I know there's some costs involved, which the patient will have to share, but yes. Question?
Okay. Okay.
Yes. If there's a question, please let
Oh, I don't think there's a question.
Oh, okay, good. All right. So we need to go back and redesign is possible. So we're looking at this anatomic start, is that implant position, is it prosthetic design, or is it technical support? And also, what about the loading patterns? So showing we have a problem in prosthetic design, well, we can fix that up. Okay, we can't do much with implant positioning. We can probably look at the prosthetic technical support, but we also need to manage the loading design, loading pattern. That's really crucial here too. So when we talk about how do we plan, and we talk about the stabilizing and diagnosing and definitely treatment and followed by maintenance. In my practice, even this particular patient, they sign off that the maintenance program starts before you start the treatment. It's drummed in their heads. Now I'm taking recordings. Today I had a patient, young man, 32, who was just mutilated from drugs and smoking alcohol. He's recovered. Parents are very lovely, educated people, and you want, never blame the parents. Let me tell you, it's the kids as well. We should stop blaming the parents. Some parents have got beautiful people and it's interesting that when we think about this, what the kids did to the parents, and the mother couldn't even look at the teeth because I was trying to explain what we have to do, and we decided only do lower implants. It's a full mark clearance within the upper denture, upper full maxillary dental prosthesis, and lower fixed prosthesis with implants, because I don't want to take too much risk in having failed maxillary implants. We can get rid of mandible. I don't want to take the risk of failure in the maxillary implants. And that was a decision made to also reduce the costs, and also I think the best treatment for this particular patient. Now, the maintenance therapy is a paradigm changer in this patient. And the patient said to me that when you send me SMS, it said cleaning only. It didn't say you're going to look at my teeth. See, people will find every excuse in the world to throw the blame at you. When it's very well stated, that's why when you do a treatment plan, you need to write the rationale why you are treating that patient in that particular way. Because that's not the thing I ask. And I ask to give a report. Usually I like to talk to them. So tell me the rationale, tell me what you did. Okay, good. Yeah, that makes sense to me. That's great. But when they say I just did it because I felt like it, that's what told me, it doesn't stack up. So in this particular patient, she didn't turn up for a 4 to 6 months of a regular checkup. And to me, that's critical. So I made sure that. So that's a paradigm changer. So when we talk about it, okay, the most important thing is you need to change that paradigm. Even though my patient didn't accept that, she knew that she has been informed. So going back, what's a clinician's responsibility is to get a paradigm shift, paradigm change. And the patient's responsibility to adhere to the program that's clearly stated. So in the case the patient didn't return to me, went to another colleague, there was a problem. I said, hang on a minute, I haven't seen you for 2.5 years. And I'm given a chance to assess my prosthetics. So I've answered a lot of questions, and hopefully the redesign in this case, and I'll bring it up, in a college program where you do your diploma, you'll get to see these 4 cases, and this is just only part of the slide. You get a whole lot of cases, understand how the whole thing works. Now, coming back to the distal implants, any questions so far?
No questions. None. All good.
Okay. I talk about distal implants. Why did I want to put distal implants? Because I usually follow the Facebook. I see people showing me failed implants in distal, and someone mentioned to me, Sarkis, why don't you tell me, so look, I said, that's case by case basis. I said, well, can you just give me the recipe? I said, I don't give recipes. There's just one thing I don't, because to me, it doesn't make sense. But all I can do one thing is that distal implants are non-splintered with the highest failure rate, both in the maxilla and the mandible. Look at all the data, you can break it out, and if it's splintered, it's a different story. But even when it's splintered, in the maxilla, it's the distal implant. In the mandible, it is splintered, usually the anterior implant. And can someone tell me why?
The bone type.
Say it again.
The bone type tends to be a D4 in the upper maxillary area.
Right. And what about the mandible, William?
The mandible.
On the mandible, it's usually anterior. Why?
Also, the patient's ability to clean and manage that, and plus the increased stresses in the posterior region from occlusion that springs to mind. But their ability to clean is very poor as you get further back near the tongue as well, as you get further back.
Very good. What about the mandible? What do you think is the most failures in mandible? This is an all 4 type situation. What do you think is the most failures in the mandible?
The distal angle development?
Yeah, it's funny you say
that. And it's cantilevered as well.
Okay. Lindquist did a study in the 90s, and the more failures occur lower anterior side because there's a lot of plaque accumulation and smoking. And so when you're smoking, you're just basically damaging the lower anterior side. But that's an interesting case. But nevertheless, if it's unsplintered, distal implants are notorious. So the problem is that you're going to find the cases that distal implants, I need to be replaced. So how do you deal with that situation? And how do you manage those cases? Let's look at the other case. You can see in this particular patient that although you haven't clinically examined, but normally when I get the OPGs, usually referring dents on the OPGs, and I look at those cases, and I look at the whole dent. This is a very old the OPG, I mean, it's 2007 pre-vision era, but nevertheless, look at the joints of the patient's loading is changing, it's adapting, okay? It's not clicking, patient's fine, no opening, no TMD, nothing, okay? So not a large or TMD, none of that, it's loading. Now, if there's a change in patient's life circumstances, stress, it's going to load more, and something has to give. You're going to heavily restore that tissue, something has to give. You can see the multiple crowns. So there's a reason why it happens, right? There's a reason why it happens. And again, we go back in a year's time, the crown was placed, and the tooth failed, the root therapy was done. Something must give. And in this particular case, you can see that there's a draining sinus. And it's that's a J curve formation. It's very hard to see J curve. That is most likely we have a J type or inverse J curve formation. There's a good chance there's a root fracture. Not all J curves are root fractures, but if you see, there's usually a good chance of a root fracture. So the polygon might have a look just to confirm. You look at it, says don't understand the patient's root fracture, so just take it out and think about it. Well, fair enough. So what am I thinking? Same forces that caused the root fracture on the crown, and the crown is well made. There's nothing wrong with the crown. Okay. Unfortunately, crowns is a common crown. All right. And it's very common amongst the common crown. And which I placed, which I should have done, but I did. The patient's fortune, it doesn't happen anymore, but we did end up having it this time. And we'll naturally be able to remove this tooth. And allow things to heal and come back. And we go ahead and place the implant. You notice that when I place the implant, I place it not too far out, but a little bit closer to the tooth, because it's the right place to place the bone. We have reduced buckle in the width, as always. So my intention would be place a smaller molar here. But the other thing why I would say looks like is why do you need to put implant on 1.7 or 2.7? Not really to reduce the opposing supereruption of the tooth, but if you notice very carefully, there's a foot impaction here. Can you see that? And so can someone tell me why there's a foot impaction? William, you go ahead, mate.
Open, not so good a contact.
Yeah,
mesial contact.
Moving distally. Okay, there's nothing opposing, and most of the foot impaction occurs in adult population is either between 5 and 6, there's no 7, or between 6 and 7, there's no 8. Okay, it's very common. I mean, I'm sure probably anyone in this lecture, when you eat, most of the foot impaction happens between 6 and 7, most of the time, because it's just there's no age, it's still the movements. So teeth move and you get the foot impaction. So one of the reasons I would say the rationale behind me placing an implant on 1.7 is to actually push this back in and create a fixed contact point. And that's exactly what we do for these patients. Okay, so when you place the implant, you place the implant, it's smaller in size, flat occlusion, all state occlusion design. And what we want to do is to push this forward and improve the design, the contact here. You can always replace there's not good contact. And we can always replace the composite, improve the contact, but something needs to be fair in this tooth or moving back. And that was the rationale behind, natural always direct screw access, you don't cement crowns. I mean, how many people cement their crowns in the audience? Can someone tell me? How many people cement?
No.
William, you do, how many people cement their crowns in the audience? Can you tell me?
Oh, no, nowadays, very few. You prefer screw retained if possible.
That's right. That's right. There are still people who belong to certain gurus in the community. They cement, and I just cancel the point because it's the worst thing you can do in the implant industry. Okay, there's no reason today not to screw the implant the crown directly to the implant. Okay, there's no reason. There's no reason to that. It's indefensible. Even if there's an excessive errors, you can still get a good result. So, having said that, the idea is to push and improve the contact point. Okay, and that's what you want. This is an onlay placed, I think, for the patient in the I think overseas, but nevertheless, we're trying to improve the situation. So that's fine. Okay, that's all good. But the way we manage the occlusion here, is basically be all contacts, and this is going to be just touching and be clear from all the other areas. So the role of the implant, they should maintain a contact pattern for me. And just leave it in mastication, and same concept as reducing or eruption of the poison tooth if it happens. But nevertheless, that implant's role in here is not actual major loading. Okay, I will always look at that, look at the poison tooth. I don't want to see any heavy contacts on this implant on the right hand. Okay, if you have minimal bone and your implant short and fat, more careful refinement is required for that. The patient's recall or recare visits in your practice, and the patient needs to understand. See, I love educating our patients. They come in my consulting room and they look at it, they understand it. When they see it, they then own it. Okay, you can lay them on the dinner chair and talk about romantic novels, they wouldn't know and hear it. When they actually stand them up and sit them directly on that, they can actually understand. And because when you get a patient who presents in the practice, and after 7 years, they lose an implant, and you haven't seen them for a while, and this is loading, and I can tell you this is loading. There's no periimplantitis, periodontal, peris control. This is a loss of disintegration. This is loss of integration. It's symptomatic. It's not mobile. As you tap it, it's symptomatic. Okay, suddenly became symptomatic. I'm not sure it hurts. It's not mobile, but something's going to happen. You can take the implant crown out, for healing abutment, let it go for a while, see if it improves. Maybe there's a bone turnover. Maybe something's happened. We don't really know. Maybe patients go for hormonal change. We don't really know. But after a while, they did start to develop symptoms. And you can see if you could unscrew this implant, they can go back in here. You can feel the serrated patterns of the screw threads in the bone. So this is not periimplantitis. This is related to loading, I think, or could be other factors. But for some reason, they decided, you know what? We can't maintain the osseointegration in this area. Can someone tell me, how does osseointegration work? Can someone tell me, in your opinion? I mean, anyone, please? And what do you know? Must be a few colleagues here who've done implant deployment. They've had a chance to look at some literature. Can anyone help me out with this, please?
Dr. Sarkis?
Mm-hmm.
There's one thing foreign body reaction.
Go ahead, Natasha.
A foreign body reaction, that's what someone said.
Formal reaction. Very good. Very good. Sharon Agami. Okay. So can you explain to me, please? I mean, that's a really good answer. Tell me, how does it work in the sense, how do you get, how do you get stability, and how do you get instability? You're on the right track.
It says inflammation, immune theory.
Yes, this is information how you get a bone there. It's good that you can talk. It's better if you talk. It's much nicer. I'd love to talk to you.
From contact osteogenesis.
So contact osteogenesis information in the
Like primary and secondary methods of, making a mechanical apposition within the bone, the osteotomy, but also the secondary healing effect incurring by, osteoblastic and activity around that site.
okay, accepted. Well, what I think is that's really good, and we knew about this number of studies. We want a good primary stability, so there's no micromotion, and that's important. And the secondary stability is when the healing occurs, and you have the bone dies and a new bone, which is a distance osteogenesis. I mean, we like contact osteogenesis, which is more to do with the surface tension implants, and you get bone formation. But I was also mentioning about Shayan Agani about foreign body reaction. Now, how do you get a bone with foreign body reaction? Can someone explain that to me? I'm happy to wait.
Via the inflammatory reaction from arterioles responding to the site of trauma, and just basically delivering a wound healing reaction.
Have you ever seen apical osteitis? So there's a tube with a chronic infection, and there's a formation of an area.
Yeah.
That's from infection, right? This is, see, what happens is that it's creates the immune response to the foreign body that's placed inside the bone. And that immune response, provided, as Brennemark said in his early papers in the late 60s and early 70s, that is how you handle the bone is critical.
Yeah.
And that hasn't been really taught much anymore, because handling bone is the most important thing in implant dentistry as well, from a surgeon's point of view. There's a lot of studies done where different surgeons have different success rates. So the chap called Thomas Albertson, I remember talking to him, he's very well known in implant circles, he's one of the most distinguished authors in dentistry, in implant dentistry. And I finally said, well, what would you do to, who would you get to do your implants? So find me a really good surgeon and I'll get to do it. So surgical management of a bone is extremely important. And that takes time to learn those important little tricks, you could say, how you treat that bone with greatest possible respect. That's important. And that will determine the messaging or signaling effects, whether you're going to get osseo integration or fiber integration. It's an immune response. And the same thing happens when we go through disintegration. Okay, something happens to the immune response that decides that, you know what, I no longer want to have a long-term, bone line in this implant. I'm just going to let it go. And that's how we lose implants, where it's caused by loading or not. It's hard to know, but my experience has shown that in this situation, this implant, a loading may contribute to the disintegration. This is pure experience. There's no real science, but pure experience because of the microfracture. So loading can cause microfracture, which will then go for the cellular process, signaling process, reversal Rankel system, which will activate, the fibroblast to replace the bone with fibro fibrous, lining material. So that's something happens eventually with a period of time, and then you get problems occurs. So I hope that sort of gives you some sort of an idea where we are. Now, on looking at it, I think MRC doesn't work. You get the body trying to separate the foreign body from the soft tissue, you get encapsulation bone, you get demarcation. Well, it's all good, soft tissue discussed, but the problem is that you have demarcation here. You can see that, okay? So you get the body trying to separate the foreign body from the body, you get soft tissue here. So again, it doesn't matter. You get encapsulation after this happens. If you leave this long enough, you get encapsulation. So that's the old theory, but basically this is what happens today. But thank you for that. That's a good comment. Good comment. So you can see loading appears under control, and same scenario. Okay, the disintegration is gone. So in this particular situation, what I normally do, and there's no infection, I have no hesitation in replacing this with an implant immediately. So there's no infection, tissues are normal. Gently remove the implant as soon as you can, and you can fill the serrations, clean it out, and then go back up. Usually, if you've got enough room, take your CT scan. I like the max implant, and it's the shortest one, 7x7. Now, then usually when you place it, you can't see it here, but bone actually is right into the top of the thread here. Okay, so this is missing right here, but this is just top of the thread here. So you want to put the implant in the right position. And you let this heal for 3 months to go back in and load it. So when we think about replacing the implant that has failed and survival, it's generally lower than the original implant that was placed. And mostly we need to do rough implants, which is normal. We don't do rough surface implants, they're smooth. But it's about around 86%, 85% of the treatment, in most initial. And it's mostly related, the initial implant failure. It's mostly related, this is the latest data, it's a new paper here. Mostly related to the bridge that are modifiable, such as implant architecture, type of implants you use, anatomic site, infection, and occlusion overload. So from the clinician's point of view, you can modify biology or biological response by looking at simple scenarios. How do we treat the bone? Removing the fixtures, allowing infection, there's infection to settle, and then placing the implant and loading it with the crown and reducing occlusion overload. So when you place a second implant, you have to be extra careful to make it work, and you have to help the biology to make it work. And the same goes with the mandible. There's a patient referred by my good colleague, Dr. Howard, and the left side was fine, the right side failed, and occlusion was favorable. And in this particular case, we didn't worry about a losing tooth because you know where it is. And that's the implant placed almost like 10 years before. So we were in a position to remove and plan. The max implant actually goes all the way. There's plenty of bone here. Now, a lot of you, if you have a problem in terms of placing immediate implant in molars, I do this quite often. There's a way to do it. And in particular, if you have the right anatomy, max implant is very good. As a distal implant, that gives you better stability. So it's quite common in my practice. Distal is all max implants. In the mandible or maxilla as possible. And again, you plan and make sure that you're in the right occlusion table. So on DTX planning, and these are treatment progress. We modify risk factors, and this is an angle here. So you think that occlusion is high, it's not just the right level. The actual occlusion is different level. It's just very hard to see, but it's in the right level of occlusion. And again, we modify all the controlling factors that we can to help that patient. Any questions so far?
Yes, Dr. Nalbanian, just asking also, do you prefer external hex, type of implants for posteriors versus anteriors for internal hex, or do you have a preference?
Yeah, I always, most of the time, it's external hex. There's no data.
Okay.
Okay, I use internal as well, don't misunderstand. but there's no data that tells me that the internal connection is better than external connection. Why would I? Perhaps you want to ask me, why do I like external hex?
Yeah, why do you? Yes, exactly.
That's the question you want to ask me. Okay. And the external hex, you have a posterior screw is changed immensely, right? You got a nice thick posterior screw. Second thing,
Yes.
in the narrow implants,
Mm.
the external hex is far more stronger than any internal connection.
Yes.
Okay. Now the world's going towards narrow implants. Okay. And short and fatty implants.
Mm.
So narrow implants, once you start using it, if you look at this patient here, they're external hexes, and this is narrow implant.
Yes.
That's a narrow external hex. That's a narrow one. Okay.
Mm.
That's a regular platform. Okay.
Mm.
Now, if this was internal, this was a fracture. That's it. That's the question.
Yeah.
This is a fracture. So did this one. Okay.
Yeah.
So now Palachi, he's on external connections, narrow platform, 3.3 millimeters all around. He does full maxillary mandibular application all the time. And now it's got one of the best papers ever written. So, you know, as a clinician, I look at data, read the data, and make my own decisions. So,
Thanks.
you know, does it make sense to you?
Yes. Yeah.
If this same implant was here,
Mm.
it's a really good question, by the way.
Thank
Always
you.
think I have to. That was a snap.
Thank you.
She did in the first place.
Yeah.
I mean, this is so obvious.
Mm. Yeah. The only fracture I've ever had is with a narrow anterior lateral placed implant, the screw fracture, and with the internal hex design, and it's bloody hard to remove
It's a
a
nightmare. Look at
fractured
the screw
internal
here.
screw.
This screw here, right? It's a nightmare.
Yeah.
It took me 3
Yeah.
hours to remove the screw. It's a
Yeah.
nightmare.
Yeah.
Okay, and then always I get referrals to remove screws. I'm now well known for that. You know, but it's a nightmare.
Yeah.
So thank you for your contribution. I appreciate that.
Thank you.
Enjoying the lecture, by the way.
Yeah. Yeah. I love it. Thanks for your lecture, by the way. I love it.
Thank you very much. So just coming to my final slides. I just want to come to the final slides. Everyone's texting me. Sorry about this. Just 1 second. 1 second. Now the plan. Going. We talk about this one, that one. So this is disintegration. See, what I want you to start looking at is the fact that when we look at a raw pattern and patients start doing the blame game, don't be upset because you know they pay for this and they want to work, but just be a bit more look at a bit more laterally, understand where the patient's coming from. They have every reason to be upset too. They can't see them now. You can. So that's why good photograph, good visual effects are so important in your planning of the treatment for this patient. And this is my final slide, is that in many ways, you know, you need to sort of look, you know, the picture with both of your eyes, you know, is remove the other hand. It's so important to have a really logical thinking. And it all comes from the initial planning. You know, I would never sort of ring the ladder and say, "Oh, it's your fault," or whatever it is. It's a joint effort of trying to solve these problems, and patients really like and respect the fact that there's a problem, and you took on that problem, and you were able to, you know, find a solution for them. And I understand there's a lot of times I can show implant complications is like a whole day lecture. It's just a small snippet of it. We should teach the program. And this is the thing, you know, we have to stop the blame game and understand, well, how can we really help our patient? And that's, I think, the most important part of the treatment plan. And that's my end of my lecture. Is there any questions anyone had? No questions?
None so far.
Well, William, thank you for asking all these questions. It's something to think about. Dr. Howard? No questions? Nimesh?
So far, not. I think you have answered the question about the distant maxillary molar implants,
Right.
why we had to place it, and of course, I think that was my question. But I think you answered it already, just to stop the movement of the premolar or a molar and to avoid the food impaction. Because I think often we think that, do we really have to take an effort to put an implant in the distant molars?
That's right. That should be your rationale. And that's a good rationale because you're explaining that when you put the contact pattern, and that's very important.
There's actually a question.
Yes.
Would cementing implant supported bridges reduce pressure on the implant and reduce the failure risk?
The cementing implants or bridge will reduce pressure on the implant. Interesting. Alexander, are you taught by Mish or have influenced by Mish in the past? Can you answer that for me? No? Okay. Yes, go ahead.
I'm not sure. Is anyone else asking a question? I just wanted to just quickly check with you, Sarkis. Just with talking down the crown abutment system, do you sometimes bring the patient back for the final talk, or say you establish your talk, but because of the machinery, because of the machining aspect of what's happening, do you then set it up and bring them back at a separate occasion to do final talk at all?
Okay, look, it's been recommended by certain authors. I don't, but what I do when I actually talk finally, I hold a talk for about a minute.
Okay.
Okay, that's a good question.
Yeah.
How you do things. All right, you want to hold it for a minute. Imagine being back, taking it out. It's a nightmare. Okay, but the other important thing is that I've done a lot of this, but when my hygienist, my oral health therapist and also my dental colleagues like Natasha is really highly trained in recognizing this. So it's having a team support that can recognize this, and things don't skate for the net more or less. Sometimes they do. There's no question about that. I profusely apologize to the patient, but but something that usually happens is some of my patients been elsewhere or referring dentists or anybody that restored the opposing tooth, and it was okay, nothing was wrong, and then things happen. I realize that opposing tooth has been restored. Okay, so this is why sometimes I'll tell the patient, if you can't make it, come every once a year, and let me just. The first thing I do is check the occlusion, make sure it's not loading, make sure it's all clear, and it's fine. Then the referring dentists can do whatever they want to do. It's fine. Now, I want to ask a question here. Just from experience, I find there are a few complications with loosening of bridges or screw fractures. Okay. All right, a few complications. Okay. The problem with cementing a bridge is that if you feel there's few complications from screw loosening or screw fractures, then if you're cementing on something, what happens is the screw that actually is joining the button to the implant gets loose or fractures. So you have a mess to deal with. The simplicity of the system is to be able to have retrievability, number one. Plus, implants are usually deep placed, and even though if you put your buttons at the subdivision level of 0.5 millimeters, you still have cement somewhere. You're just complicating it, and also prosthetically, it's far more expensive. So having a simpler, see, the good design is a design that works, it's functional, it's aesthetic, it's easily retrievable. If something goes wrong, I want to get to it. So, usually every year, if my hygienist feels like I need to remove the superstructure, then I just go and remove them, I remove them, take them out, she cleans and put it back in. If you cement them, you're just complicating your life. I've done this before, and after 15 years, we still can't remove the bridgework, it's going to stay. The good thing is there's some recession, there's some implant screw exposures that my hygienist goes around and cleans them, but is that the right thing to do? No. So most of the time, I would say 99% of the time, all my restorations are directly screwed to the fixture. It's on a button level. So we mount in the buttons, then cement on the button level. Because again, if something breaks, see, the good thing is when a screw does break, it's a gift. It tells you there's a problem in the system that's loading. So that gives you the opportunity to revisit your design, your prosthetics. That's very important. You're able to remove and check and put back in. I don't want to make analogies like the Mercedes cars in the early days and Jaguars. Every mechanic used to complain about Jaguars, is to change some spark plug to take the whole engine apart. Okay, and no offense, I love Jaguars too, but Mercedes was easy. They could get to it and get it out. So that's important. A good design is not only hygienic, retrievable, and patients understand that. And you get your patients involved. Planning. Tell them why you're doing it. It's good. Those who are interested, they like to learn.
You've got another question, Dr. Sarkis.
Go ahead.
What type of rescue kit do you use to remove a broken screw?
Well, every manufacturer has their own script. So you can't use what I use on external hex implants on what I use on internal implants. So there's two different things. You have to talk to the manufacturer and be very nice to them. If you're kind to them, they'll help you. And I'm fortunate enough that I'm very kind to all my dental representatives. They're my good friends. They always help me if I need a particular product or if you need a particular parts to be able to retrieve a screw. If you haven't done that, get some with more experienced colleagues and then learn how to do this, because it's very tricky, especially not the external hex, but the other internal connections are very hard to remove. I find that if you have ankylose or if you have the Astra, they're very hard to remove the fracture screw. But any external hex, it's just a piece of cake. But the problem is when you fracture a screw, if you don't know how to remove it, don't touch that screw. If you get an ultrasonic and try to touch it, that's going to rotate and lock the bottom. That's the end of it. So please, if you haven't done it, okay, don't touch it. Just get the patient, someone like me or any other prosthodontist who are experienced dentist who's done this before to remove it for you and go and watch and learn how to do it. So, that's really important. Good question. Is it better to use titanium? Natasha, can you read this for me? Next one.
Yeah. Which one? I can't see that one. That might be a direct one to you.
Oh, is it better to use, is that right? Okay, Ryan, okay. Is it better to use titanium-based abutments rather than zirconia-based abutments? What's the reason why the bridge abutment narrow implant structure? Now, good question. We use titanium abutments. It's the tubing that fractured. Okay, the tubing that's actually, so the way we do the tube is the tube cemented to the titanium abutments, and the titanium is actually onto the implant surface. But the question you should be asking, for instance, how would you restore this? I think what we would have done in this particular case is two things. Either we could have done this metal ceramic with a full occlusion of metal, and you have a buccal porcelain. That wouldn't have a problem. Okay, that's one way. Another way of doing it was to have mounting the abutments and bring it further up to tissue level. Okay, and so if it fractures, you're fracturing a little prosthetic screw, so you can undo it for a new prosthetic screw. Again, you have to manage the loading. So the question is the loading and nothing else. Because if it's loading to a degree, Okay, either your screws going to break, most likely, or your implant's going to break, or a bridgework's going to, chip or break, or type or the zirconia will basically fracture. Well, the zirconia doesn't fracture that easily. It's very strong. It's very actually stiff material. But somewhere along in the system will be a give if you don't manage the occlusion if the patient's severely loaded. The other question is, which is a really good question you're asking me, is that last 2.5 years, I have no idea what's happened to this patient's life. No idea. They could have developed some funny habits, chewing or biting, whatever, and enjoy their new teeth. We don't know what they do with their teeth. Ultimately, we don't know. Any other questions? Good question, by the way.
Just a quick one. With removing an implant itself, unless there's so much inflammation and bone destruction that it is somehow easy, if it's still quite fixated to the bone, it's no other way than trephination and losing a bit of bone, then quite a bit more bone through trephination.
Okay. The one you saw on the distal one, on a single tooth patient, I could put the actual mounting attachment and just rotate it. Eventually, okay, that was my testing tool. But if it doesn't have to, well, especially the fractured implants to integrate it.
Yeah.
Okay, you have to tray find the upper fin or the tray find it. Because every time you tray find it, there's no bone left. Like if you want someone to blubber their mouth and say anterior to fin, just tray find it out. There's no bone left.
Yeah.
Okay, so what I use a special piece of surgery, and we just go very slowly. And some people also use electrosurge, just zap the implant and it just disintegrates. I haven't done that before, but or I just think about something like that rather than cutting the bone away. That
that makes sense.
It just allows that little bit tweaking. And work for a couple of days, and the whole thing will solve. The bone around the implant will die, and then you'll be able to remove it. But I have not tried it as been suggested. So people swear by it. I haven't done that, so I'm not recommending it. So just go ahead. So the less trauma, the better. That's all I can tell you. Because you at the end of the day, you live with it. You see, I see patients here coming to be like the end of the run, more or less. And unfortunately, a lot of them have got. And there's one particular patient, a lovely man, and yet grafting on the anterior maxilla to have implants. And every surgeon said I can do a better job than the other surgeon. He did a job, he lost more bone. Next one, no bone. Next one, no bone. The next is no bone. He's got a thick acrylic pink porcelain across the bridgework. Now he has food impactions there, everything's there. He is really, really upset. This is a one implant solution. The trouble is, he's got a type of bone. Thin biotype, and just when you touch it, it just melts away. And we'll probably talk about that when I do a lecture with my very good colleague, maxillofacial surgeon Peter Tsakiris. We'll talk about some of the difficult cases that we manage, and really difficult cases to manage, but if you're interested in those. But these cases are more applicable to their practices, and we teach in the college in how to think, how to integrate. So people coming in the college. There's some experience in implants, there's some experience in other areas, but this tells you a bit more into how to think, what are the other possibilities.
Dr. Sarkis, you got another question. What criteria do you use to decide whether to restore bridge with direct to fixture screw retain versus multi-unit abutments?
That's a very good question. Up to about 3 years ago, whenever I could get away with direct to fixture head, I would. But nowadays, realizing that we have a mobile population, and if patients if for instance aesthetics is not an issue, I would always consider having the platform lock higher towards the gum using multi-unit abutments. Now, that would be one criteria. And naturally, the angulation of the implant will be another criteria to improve the access. But remember one thing, no matter what you do, if patient is loading, they'll be giving the system. So in this particular case that you saw initially, the second case, I've changed it to multi-abutment. So she's coming tomorrow, we put a new multi-abutment and take a abutment level impressions and make a new bridge. In that way, we can control the situation, and it's easy to manage the situation. You can only replace the prosthetic screws. But when a patient does fracture zirconia tube in the house that has the abutments, that gets more complicated issue, becomes more major complication. It's not a minor complication. The idea is to manage complications from going from major to minor. Still a complication, but you can fix it at chase side. And I think I really appreciate that question by Alexander Meyer. Thank you very much. Very good question. Almost to your level, William. Good questions.
Thank you.
And thank you. So that will be my criteria to manage this patient. Thank you.
There's another question, and that one says, do you prefer joining posterior implants over separate ones to get better stress distributions? Sometimes joining implants may cause stress strain.
Okay. I want you to be more specific. Okay, let me ask you a question. Posterior, so you're looking at full maxillary arch, so you got 6 implants. Are you saying joining, let's say, 3 one side, 3 at the other, or 2 on each side, and perhaps 2 anteriorly? I mean, can you tell me which scenario would you prefer me to discuss? Adjacent to quadrant. There's a lot of good clinicians that I know that do exactly what you just said. They sort of do separately, and that's fine. I normally, because I get a passive abutments, I get a good cross arch anchorage. I like that idea of having a splintered framework. Looking at Scalax model, if you know about Scalax, is a biomechanics. You look up Scalax, you'll see some of his calculations. So he's a theoretical physicist and a mechanic. I mean, there's a lot of work in the implant industry. He'll work for Noble Biocare. So if you have a round arch and it's splintered, okay, you actually can redistribute stress, okay, better. But having said that, there are situations where clinicians prefer to simplify and have 2 separate ones and anterior 2 all separate. That's also a possibility. It's on a personal level. So if I think, for instance, I'm not happy with my prosthetic design, and perhaps maybe other issues available. If I think I'm going to lose an implant, I'm not quite sure, and if you have a correct distribution of the implants, and I will go full arch, because if I know that if I lose the implant here, I can still manage for the successful management of the prosthesis. On the other hand, the disadvantage of having segmented situation would be if you lose one, then your prosthetic, that segment is probably guarded. That's something we should think about. So the highly bruxing patients, I would prefer to have a cross arch anchorage right across and manage the occlusion better that way. Very good question. Right, thank you very much. Good question.
Thank you.
Thank you. Isadora, thanks for being part of it. Sorry, Izzy, it's every second Tuesday.
Always a pleasure, Sagas.
Izzy was asking, he's not in the mailing list, what's happening?
Yeah, something happened, Sagas. Not to worry, I'll be back for everyone from here forward.
Thank you, thank you. Izzy, happy to answer questions, we just know what generally means. But
Thank you.
one thing that was, okay. Thank you. Thank you for your lovely wishes. I'm getting all this. Any other questions? I'm happy to help.
When does the COVID lockdown finish?
Well, that's a good question.
You don't have to answer it.
It's ruining my life. Of course,
Sure, you've got some contacts, Dr. Sarkis.
You're
I love
welcome.
your Zoom Tango, by the way.
Fantastic.
Oh my God. Why do you know about that as well?
Website.
Great mind thinks alike.
Just turn the surgery into a Zoom tango class.
That's what. That keeps my sanity, Natasha. That's why I come to work. You see, keeps my sanity.
You never come to work. You come to enjoy.
That's right. I can't. That's very true. I come to have fun. My wife, she when she gets angry at me, she says, "But you never work. You used to have fun. I mean, don't call work." So I can't complain. You know, I can't say, you know, I really work hard and you know. Oh, there's a question here. Natasha, there's a question here from Alexander. In terms
Oh,
of
yeah. Oh, it's just new. Okay. It says, in terms of torque, do you usually apply less torque to bridge restorations compared to single units?
no, same, no difference. No difference. Implants only have maximum 10 microns, 4 to 10 microns. So same torque. You know, implants are extensions of the bone. So torque it as per manufacturer's instruction. So can someone tell me what does the torquing achieve? What do you do to the screw when you torque it? What happens?
It elongates slightly
Right?
and engages via its internal threads. You know, like machining, if I could generalize it.
Yes. Okay. A bit more, William.
Yeah.
Anybody?
Alexander says cold welding.
Cold welding. That's more like the old Straumann system. Okay, fair enough. That's the abutment because it's conical abutment. You could say that. Okay, I want more. Like you got the screws. You torque the screw. What happens? I mean, what happens? How does it grab? You know, can you explain to me how it works? Anyone can think how it works?
I'll go with that elongation theory. It's you know, the
Elongation,
metal
but
stretching of the metal.
yeah, tell me more.
Alexander says friction.
If it goes more, you snap.
Yeah, but can you explain to me?
Sorry.
I'm with you. I'm with you. What happens before it snaps? Just think of. I mean, you done metallurgy or you done, huh?
You can feel it slide a little bit right at that 35 Newton centimeter. You just feel that sort of like a little slip.
Okay.
That's just from a feeling point of view of what I, you know, look for.
Right.
They say elastic deformation as well. That's another comment.
Yeah.
Sinead, very
Yes.
good. So what happens, William, is that when you torque, okay, to the specified manufacturers, okay, usually if it's a regular platform, if it's external hex, it's about between 30 and 35, okay? Doesn't matter if it's a narrow or whatever, or regular or wide, but 30 to 35 up to 40. And when you do that, okay, the screw you want to stretch the screw to this elastic range, okay? It's elastic range that way actually goes elastic, grabs the two parts and pushes it together.
Yeah.
Okay, that's a function of the screw. It's called screw mechanics. And that's how it holds it together, okay? So if you go past that, then you go into what? Plastic range, right? Stress. So as you stress strain curve, right? That's elastic range, right? More stiffer, the lesser range. And you know, you want this so. So what happens is that as it goes past that, it goes into plastic range, necking, and then eventually snaps off. Okay. So what happens when you have a occlusional loading and then that jiggling movement, okay, pass the screw into the plastic range. That's why you can't get that screw back screw inside. You have to change it because that screw is no longer giving you the elastic range that you need. That makes sense or not?
Yes.
So I like Cheyenne doing a great job for your answers. Thank you very much. I wish you could talk, but you don't want to talk.
I think some people's microphones don't work.
Can you get his name and send him a microphone as a present, because I'd like to talk to him. He's asking all these lovely questions.
Can do. I'll organize for that.
Free microphone coming to you, Shane.
Oh. Oh, he said I've been attending your lectures for a while, so slowly learning.
Well, when you come into the, I think, is he in the program? I'm not sure. Should be in the program. It's really good.
I can't remember. I'll have a look.
Well, anything else I can help you with about this section?
I think we're all good. It's my bedtime anyway.
Natasha, thank you. I hope I was a good boy today. I was, you know.
Oh, I don't know. Rhetorical question there.
Yeah.
That's
You can
right.
only try.
Yeah. A for effort.
Right.
C minus.
Well, thank you so much for everyone. Thank you very much.
Bye,
Okay,
Dr.
bye.
Sarkis.
Take
Thank-
care. Bye.
Thank you.
Thank you. Thank
Thank
you. Bye.
Thanks,
you.
thanks,
Bye-bye.
Sarkis.
Thank you. Thank you.
Bye.
All the best. All the best.
Bye-bye.
Bye-bye.
Thank you, doctor.
Thank you. Thank you.
Thank you very much.
Thank you. Take care.